Thank you. So we move on to the next. So we change gear a bit again. We go to distal weakness, but this time it's a genetist who, Marco Savarese, working in Helsinki, Finland, who gives his perspective on this category of diseases, and it's very interesting. And I challenged him the second time now.
Yeah, no.
But he can do that very well.
So thank you so much. So I'm Marco Savarese from Helsinki, no conflict of interest, and I said I'm not an MD, so I will give you my perspective on this topic. We will start with some definitions and with a general introduction on distal weakness and distal myopathies, few examples of distal myopathies, underlying the genetic and clinical complexity, to move then to other diseases, and in particular to the multisystemic proteinopathy. So the distal weakness is defined, of course, as a reduced strength in skeletal muscles, for example, in the upper limbs, which mean hands and forearms, which means also that the patients will come to your department complaining about some daily activities that he or she cannot really do, like opening a jar, like zipping, unzipping, buttoning, and so on, or the lower leg, the anterior compartment with frequent falls, tripping, and difficulties in walking or running, the posterior compartment with the difficulties in standing on tiptoes, and the combined anterior and posterior weakness with eventually some balance issues. What you see here are the hands with the thenar and the hypothenar region muscle atrophy. And this is quite typical, and we will see more picture about hands in a large number of diseases. And here, two videos underlying the myotonia, here the percussion myotonia, and on the right, the hand grip myotonia. These are, of course, myotonic dystrophy patients. Again, if we stay on the hands, here on the top, you will see, does this work? No. You will see the finger flexors issues, which means you can't flex, or the patient cannot flex basically the fingers, but for example, the fingers extensors are preserved here. And what you see here in D and E, this is a LAMA2 patients where basically the flexor issue is only limited to two fingers, the index and the fifth finger, while again the extensors muscles are preserved. If we move to lower legs, here on the left, this is a quite well-known picture. This is a wood myopathy patient, a tibial muscular dystrophy, and as you can see, the bone here is quite clearly seen, which means that the muscle is almost totally gone. And on the right, then, you can see atrophy on the posterior compartments of the gastrocnemius. But again, other symptoms, or other signs, this is in ALS patients where you see fasciculation, so this involuntary contraction of the muscle. And here the foot. On the left, this is a CMT patient, and you will see this high arch here. This is a clear sign of the intrinsic muscle weakness, and it's a clear sign of a disease that has been progressive, basically. So there has been a weakness, and this basically leads to a foot malformation. On the right, then, you will see the atrophy of the extensor digitorum brevis. This is as a normal foot would look like, and this is, of course, the atrophy. And this patient has a diabetic polyneuropathy, so it's basically a neurogenic condition related to the diabetes. So I'm not a clinician, but defining a clinical diagnosis here can be complex. And it can be complex because there can be a neurogenic component, there could be a myogenic and a myopathic component, because we know, and we have been listening today, that there are, of course, ways in which tools and tests that you can used to basically either go towards a neurogenic condition or towards a myogenic condition, and then you can, of course, perform muscle biopsy, and the myopathology may help as well. Another big issue is the inherited versus acquired, and this is particularly important when you deal with adult patients, where you should consider also the possibility of an acquired condition. We won't have time today, of course, to go through all the possible conditions, so I decided to focus basically on distal myopathies, because this is our main core business, I will say, in Helsinki, and because I think it's a good example of a complex disease and a complex condition where we can underline some specific aspects that could be useful in this place. So how to define distal myopathy? The first problem is that there is not a general consensus on the definition, on the list of conditions, and so on. There has never been a ENMC, for example, meeting clarifying the different distal myopathy forms, and there has never been, for example, a ClinGen working group to define the genes that have been or that are associated with this condition. So I will go through what we in Helsinki use as definition of distal myopathy. And we think a distal myopathy is a genetic muscle disease, primary muscle disease, which means the defect has to be a primary muscle defect. So it has to be related to a condition where the defect is within the muscle, leading to muscle loss or muscle weakness, where the patient at onset shows a distal phenotype, either hands or feet, or a combined upper limb and lower limb weakness and atrophy. What about the genes? I decided this year to show you the most recent review that Johanna, who works with us, and Professor Ruth published, I think, less than 1 month ago. And there is a long list of genes. There is, unfortunately, said, not a clear and official nomenclature for these diseases, so we still think that the easiest way will be to follow the same nomenclature that has been suggested for the Limburg-Guildol muscular dystrophy, which means using the protein name. So the first form will be the alpha-actin 2 related distal myopathy, the second one, and so on and so on. So using the protein name and distal myopathy. We also think that using dominant or recessive in the disease could be a bit misleading, or could be a bit difficult, because there is an increasing number of genes with dominant and recessive forms. You can see some of them there. And I wish to underline already now that, as you can see in this table, there are few complex genes here. Titin and nebulin, for example, which also means that we have some either technical or interpretative issues when we deal with genetic data. This is an old picture, but it's useful because already 10 years ago, more than 10 years ago, where there were few genes associated with distal myopathy, already it was clear that these genes would have not been only linked to distal weakness. And this is even more evident today, and likely we saw a similar picture in the previous presentations. Most of the genes associated with a distal phenotype also cause a proximal phenotype or either a congenital phenotype, which means there is a clear overlap, genetic overlap. And we will go back to this because it's one of the problems in this field. How do we make diagnosis right now? Of course, as you know, we heavily rely on genetic tests, and we heavily rely on high throughput sequencing because it's easy. Of course, it's easy to run and is reasonably cheap right now to do an exome and genome. However, when we have overlapping biopsy findings, when we do not have specific clinical presentations, when there is, as in this case, clinical and genetic heterogeneity, then it's not easy to interpret genetic findings. Yes, we have guidelines, and actually we discussed this in the morning, but it's also well known that in a large number of cases, we will end up with variants of uncertain significance, which means we have to do extra work to interpret these variants. Combining, as we have done in this meeting teaching course, combining different strategies, basically, and where the genetic cannot be the solution by itself, but it needs to be combined with imaging, with lab tests, with clinical examination, and whenever possible with functional tests. And we will go back to the importance of functional tests. I want to just underline already now the importance of imaging. We have had this presentation in the morning. I will not go in details through this, but I want to underline the importance of this work because it's the first attempt to try to correlate MRI findings with the specific forms of distal myopathies. And it's something that, of course, it's of interest because it will really change the approach to the disease if we can combine genetic data and imaging data. Now a few examples of distal myopathies. I start with Titin, a bit because I have in this a conflict of interest, and also because, as you probably know, the first human disease associated with Titin variants is a distal myopathy. It's the Hood myopathy, it's the tibial muscular dystrophy, and as already shown, the tibial muscles here are almost gone. This is a late onset disease. It's a slowly progressive disease with a frequent variant in Finland, which means we have a good number of patients in Finland, and where actually the diagnosis can be made also by Western blot, because what you see is the heavy reduction of titin fragments in the tibial muscular dystrophy patients and the heavy reduction, secondary reduction of calpain, which is also of interest because what we know is that if you then have the TMD variants in homozygosity, as it happens in Finland, since the Phi major is a common variant in the population, then you will have all the titin fragments totally gone, and you will have a much more relevant secondary reduction of calpain. Titin is a sarcomeric protein, which allows us to start making correlation between the defect or the disease genes and their location within the muscle. So here we are within the sarcomere, and titin spans half of it from the Z disc to the M band. What makes even the titinopathy a complex topic? Well, of course, the size of the gene, but also the fact that we have seen the tibial muscular dystrophy, which is dominant, but in reality there are distal titinopathies that are recessive. They have a slightly earlier onset, still adult, but earlier than the classic tibial muscular dystrophy. And they are still associated with variants, usually truncations, in the last part of the gene, usually in the last 1 or 2 exons. But what we know is that there could be also dominant titinopathies due to truncated variants. This is a single family reported a few months ago from Belgium. And this is actually dominant titinopathies with a phenotype which is a mix, cardiomyopathy plus either proximal or distal. This is difficult to really define, but also because it's a mild condition, and basically what makes this finding unique is that this is, at the best of our knowledge, of course, the first time that in muscle we see a truncated titin protein due to a titin truncation, which for us explains why we have a dominant form of titinopathy. But be careful, because you can have copy number variants, which means, once again, you should always be careful and ask the labs if they perform a copy number variant on your genetic data. In titin deletions, intragenic deletions are more common than what we thought a few years ago, and unfortunately the genotype-phenotype correlation is not so easy because it depends on the size of the deletion and on the specific location of the deletion. But this is interesting because also in nebulin, which is a similarly complex gene, we have a very similar finding. Also in nebulin, like in titin, we have distal myopathies due to intragenic deletions. Overall, I think this is a kind of neglected part. If you run pipelines for copy number variants, you may find copy number variants, intragenic deletions in large genes, for example. Second example the alpha-actinin 2 related distal myopathy. What you see here is one of the patients that we reported a few years ago. This also is a complex disease because everything, it's again a protein of the sarcomere. Actually, this is a protein of the Z disc. And it's kind of a tiny protein, but extremely conserved, which means that, unfortunately, there could be missense changes, and they are really difficult to interpret. Everything starts with these families, and actually with the mutation quite common in the Basque countries and in Spain, where the phenotype was I would say, classic distal myopathy phenotype with dens and feet. But then we found this patient where there was also a mild weakness of facial muscles. The situation is now more complex. Okay, here just to underline the presence of some protein aggregation within the cells, positive to TDP43 and P62. But why the situation here is more complex? Because we know that these are dominant forms, but we know there are also recessive forms. And this is a good example of why it's important to perform functional studies, because we all find variants in alpha-actinin 2, and we don't know how to interpret them. We don't know if they are causative in heterozygosity, and if you have adults, often you may not track down parents, or you may not perform segregation study. It would be useful to have something to interpret variants. That's what we are doing in Helsinki, basically. And functional study help, because right now we have a quite good understanding of why specific variants cause the disease, why specific variant cause a dominant disease, and why other variants do not cause a dominant disease, but eventually a recessive disease. And then again, third different form. This is a completely different, because while we were not so far discussing sarcomeric proteins, now we have this protein, the NGB2, which basically plays a total different function. It's not a structural protein, but it's basically associating to protein quality control and so on. What you see here is a family that we reported last year with the deletion in the last exon and the protein extension. And why this is relevant? Because we see inclusion body myopathies, and we would think that this DNAJB2 is again another example of proteins and genes related to these three functions that are essentially in the muscle, which are the chaperone surveillance, the proteasome system, and the autophagy. So, I mean, this is another gene somehow showing the importance for our disorders, not only of structural proteins, but also of functional proteins, or chaperones in this case. Then a few examples of how complex the diagnosis can be. This is an Italian family first published by Claudia Di Blasi in 2004, so over 20 years ago, or actually 20 years ago. It took almost 20 years to solve this. Why? Because the defect was a repeat expansion. As you can see here, these are short read, but still good enough to notice this peak here. This peak is not a duplication, but is a repeat expansion in this gene, SPLIN4, which is also a complex gene, because actually it's highly expressed in the adipose tissue and not in the muscle tissue, which made the gene discovery even more complex. And here the take-home message is pretty clear. I mean, there could be always something in your exome, in your genomes, that are difficult to detect, to spot, and this can delay, of course, the diagnostic workflow. And this is another example, an X-linked disease, because we are usually dealing with autosomal genes, and X-linked genes are tough, because the segregation or because the inheritance pattern is difficult to detect. These patients were, well, all of them originally from Malta, but this one specifically is an Italian patient. Hand weakness, you can see the tibial again, so somehow resembling a tightening condition, a TIA1 condition, and that's why basically the patient was referred to Bjarne and the DNA was sent to us. These are the families we put together a few years ago, and as you can see, all the males are affected because it's X-linked, but we would have never realized that if we were not able at some point to find all these families with the same variants. And to track down all of them to Malta, which clearly proves that, of course, there is a enrichment or a founder effect of this variant in the Maltese population. So, all these diseases show that the pathophysiology is complex. We do not have a clear correlation between the function of each specific gene and protein and the disease we observe, because we have a mix of sarcomeric proteins, structural proteins, functional proteins, and so on. And this makes difficult the variant interpretation. But I want now to spend a few words on this emerging field, the multisystemic proteinopathies. Now, for multisystemic proteinopathy, we mean a genetic disorder, or let's say a class of genetic disorders that affect not only muscle, but eventually bone, central and peripheral nervous system. And usually mutations in the genes associated with multisystemic proteinopathies lead to either a myopathy or either and a myopathy and or a Paget bone disease, an FTD, a frontotemporal dementia, or ALS. And no one exactly knows what caused basically a pleiotropic effect for mutation in these genes. There is, again, no consensus for the definition, and to be honest, there is no consensus on the list of genes to be included in this category, but the interesting part is that the genes here are all of them related either to transcription or to splicing and MRI processing or to protein quality control. Another interesting aspect, and we will go back to this, that in this small list there is the first example of digenic inheritance, a tier 1 plus sequestrosome, but I will go back to this in a while. Let's start with one of the most recent genes we have been associating, or we associated to with multisystemic proteinopathies, the HNRNPA1. This is the large family. Again, this is a Finnish family published 20 years ago, 21 years ago, and once again it took 20 years to find the gene. Why? Because it was this time a very tiny deletion, a single exon deletion that would have been missed by most, unfortunately, of the bioinformatic tools for copy number variants. So this is the first family. To be honest, we have a number of other families, not with the deletion, but with point mutations. And be careful because, unfortunately, several commercial exons miss part of this gene. So technically, you may miss variants in these specific genes. The second form is TIA1. This is quite well known because it's quite common in Northern Europe, in particular in Sweden and partly in Finland. You see the characteristic hands. And why this is interesting? Because a phenocopy of these patients, so patients with a very similar phenotype, were found to have a TIA1 and a sequestrosome variant. Now, the sequestrosome gene was known to be associated with multisystemic proteinopathy, but no one exactly knew, and everyone had the idea that there could have been second variants leading the phenotype towards a muscular phenotype or a nervous system phenotype or a dementia and so on. And what we found a few years ago is that when you have a sequestrosome variant, nonsense variant, for example, and on the top of it you have this variant here in TIA1, all this family and all these patients have a muscle disorders. So our hypothesis is that there is a cumulative effect on the protein quality control of the sequestrosome variants and of this TIA1 variant. And this TIA1 drives the phenotype towards a muscle dystrophy. This is a poor digenic inheritance. We go back to what we have been discussing today. Not to mix up, please, the, oh, sorry, there is an error with the, sorry, with the title. But please don't mix up digenic with dual diagnosis. Here is digenic, which means there are two different variants, and each of them will not cause a disease, but it's the combo that causes the disease. And this is a good example, TIA1 plus sequestrosome, but more recently, probably you are aware of that, there has been this large study led by the Newcastle team, by Anna Toff and by the Newcastle team with Titin plus SRPK3. The digenic are rare, but above all, they are difficult to demonstrate because you have to have some mechanism explaining why is the combo cause the disease and the single variants do not. But what you see on the right part is what we have been discussing today, the dual diagnosis, which means the patient has at the same time two diseases. It's rare, but we have a good example of that because we have had a tibial muscular dystrophy patient with an atypical phenotype, an earlier onset, and a proximal and distal weakness. And we didn't know what was going on. We were looking for second variants in Titin until we found that the patient has a DMD deletion compatible with a Becker muscular dystrophy and a TMD. So they are rare, but they can be there if you look for them. Usually when you have a dual diagnosis, then you should look for something that is rare, but then the second one should be relatively common to explain the dual diagnosis. And Becker in this is a good fit because deletions in DMD are not so rare at the end. Finally, other conditions, genetic conditions causing a distal phenotype is a long list from fascioscapulohumeral muscular dystrophy, the myotonic dystrophy, for example, some mitochondrial myopathy, the inclusion body myopathy or myositis, as you wish, the DM2-related congenital centronuclear myopathy, and so on, which unfortunately shows how complex is the topic because there is a genetic and clinical overlap. And really, you need to work in a team with geneticists, neurologists, in order to interpret the large number of variants that and then you find in the long list of genes that may be associated with distal weakness. Just two words on this, the oculopharyngeal distal myopathies, because these are the genes so far associated with OPDMs. They are repeat expansion, but I will not go to this. But just to stress that here, there is a distal involvement. So the hands and the lower legs may be similar to what you see in distal myopathies, but then there is, of course, an ocular, a facial involvement and throat muscle involvement that you will not expect in a classic distal myopathy patients. But there is a clinical overlap, and this is something to consider. Also here, this is a recent study, and I'm sure there will be more, MRI may help. I'm sure that MRI in these conditions may help to better define what is the muscle involvement and drive the diagnosis towards a poor distal myopathy or another condition with overlapping clinical phenotype. So final considerations. It's pretty clear that clinically and genetically there is a complexity because there is a genetic heterogeneity and a clinical overlap. Remember that these patients, we define this distal myopathy at the onset, but all these patients may develop proximal weakness, which makes, above all in the adults, the diagnosis even more difficult. There is a lack of a genotype-phenotype correlation, or there is a lack of an in-depth genotype-phenotype correlation, and then finally the diagnostic rate. I don't like to talk about diagnostic rate because it's impacted by several factors, but it's true that when you deal with adult patients with distal myopathies, a large part of them, definitely more than 50%, do not have a diagnosis, partly because there are few genes still to discover, part because we tend to neglect the non-genetic causes of adult onset distal weakness. And thank you so much for the attention.
Marco, again, you did so well.
Thank you, I hope so.
Thanks so much. So, this easy topic, there might be at least one question to be solved. So how many of you have patients with distal myopathies unsolved?
Few.
And all done? all the work up that the Helsinki group is
Yeah,
doing.
We have space for
Yeah,
some
yeah.
unsolved, so
So you should challenge them. So first normally send in the clinical description and the MRI, and then they will start to think.
what to do, yes.
Yes, what to do next. So that is always the approach. Now, well, it's a big overlap also to the hereditary neuropathies. So also there is something, consider this as well. Sometimes in those patients, it's very important not neglecting, and also the toxic reasons for this as well. Okay, thank you very much, Marco. Thanks a lot.